This next patient is a 4-month-old infant male previously healthy who was brought in from an outside hospital for concerns for a non-accidental trauma. Per mother's report, he had been recovering from a GI illness over the last couple weeks and had been doing well enough to return back to daycare. On January 31st, while at daycare, he presented with vomiting, possible aspiration, and then he became limp, where the daycare provider immediately proceeded with CPR and called EMS. Upon arrival from EMS, the patient required bag mask ventilation but no chest compressions. They reported that the patient was having seizure-like activity with a GCS score of less than 8. He was subsequently transferred to an outside hospital where in their emergency department the patient was intubated and taken for a head CT. Head CT showed bilateral subdural hemorrhages as well as a liver laceration from the abdominal CT that was obtained. Patient was immediately transferred to our pediatric ICU for further management. Overnight, yesterday in the afternoon, the patient did well from a respiratory standpoint, and they extubated him to room air. They immediately obtained in the ICU a capillary blood gas. The patient presented in respiratory acidosis. They proceeded to put the patient on high-flow nasal cannula for more respiratory support on 10 liters but 21% room air. The follow-up venous blood gas showed improved respiratory acidosis, and so he remained on high-flow nasal cannula throughout the night. This morning, the trauma general surgery team, when we arrived to assess the patient at 0700, he presented with clinical seizure activity, including lip smacking and right upper arm rhythmic movement that quickly escalated to full body rhythmic shaking. The night nurse reported that this had been starting to present in the last 2 hours on and off, in which she did not provide PRNs, however, to help control the seizure activity, however, had noted the ICU team as well as neurology per the ICU resident. However, the trauma team, who was the primary team, was not notified at this time. Our team immediately consulted neurology. We ordered an EEG stat as per protocol. We ordered a 0.1 milligram per kilo Ativan dose. And per neurology's recommendations, we provided a 20 milligram per kilogram Keppra load and increased his maintenance Keppra from 10 milligrams per kilo BID to 20 milligrams per kilo BID. Shortly after, we notified neurosurgery, who immediately reported to the bedside and assessed the patient fontanelle that was full and bulging intense. They aspirated at the bedside, did a serial tap, and obtained 70 milliliters of serosanguinous fluid. The fontanelle afterwards subsided and was more soft and not tense. This patient proceeded to have multiple seizures that was not resolved with 1 dose of Ativan, and so he received 2 additional 0.1 milligram per kilo doses of Ativan and until the seizures were controlled. So at this time, I'll go over this patient's review of systems. Per mother's report, head, ears, eyes, nose, and throat. Mother reports denies previous head injury, no congestion, no rhinitis, no changes or disturbances in visual tracking, no trauma to the eyes. Cardiorespiratory, mother denies any cough, no congenital heart disease, no murmurs, no abnormal rhythms. Patient, as mentioned per HPI, recently had a illness but no upper respiratory illness associated. GI, patient denies any, mom denies any diarrhea for patient, no constipation, no other vomiting besides what was mentioned per the HPI, no blood in stools, no bleeding or discharge or rectal pain noted. GU review of systems, mom denies any dysuria or changes in his urinary patterns. She denies any blood in urine. No urinary tract infections to date. And mother reports skin review of systems, no rashes, no dryness, no bruising or visible injuries noted on the skin. And from a neurological review of systems, the patient has not had any altered mental status or loss of consciousness prior to this admission. I will proceed with my assessment, physical exam, and plan. Neurologically, this patient has been in active seizures, clinically presenting with active seizures since this morning. He is currently being monitored on a continuous EEG. Seizure activity first occurred overnight. His assessment this morning, his pupils were equal 3 millimeters to 4 millimeters. However, the right pupil was sluggish to react. The left pupil did react briskly. The fontanelle after neurosurgery came and tapped it is now soft, however still full. Neurosurgery will be following closely on a daily to assess the need for serial taps. The patient is currently not tracking or focusing. He presents with upper extremity stiffness and intermittent seizure activity with rhythmic movement. He is responsive to tactile stimuli and painful stimuli as well. No spontaneous eye opening at this time. As far as medication management, we are currently administering an increase from 10 to 20 milligrams per kilogram twice a day of Keppra per neurology's recommendation. We will as well include 20 milligrams per kilogram of fosphenytoin to help control seizure activity. If this does not resolve, we will, per neurology's recommendations, additionally add 20 milligrams per kilogram of phenobarbital. The EEG will help us guide management and treatment for both clinical and subclinical status epilepticus, which is currently resolved as while we're rounding on this patient at the bedside. This afternoon, we will remove his EEG leads and take him down to CT for further imaging to assess the need for further neurological intervention. Once he returns from the CT, however, we will put him back on EEG monitoring overnight. From a respiratory standpoint, this patient required overnight was breathing 20s to 40s respiratory rate with an oxygen saturation of 94 to 100% on high flow nasal cannula. However, this morning, due to escalation of his seizure activity and seizure medications, we moved forward with intubation. So this patient is currently on an SIMV PRVC mode of ventilation. His rate is set at 25 with a PEEP of 5, pressure support of 12, and tidal volume is set at 55. We will continue to obtain arterial and venous blood gases Q6 and space them out to Q12 once stable to assess both his oxygenation and ventilation status. His lung sounds are clear bilaterally with no evidence of increased work of breathing, including retractions, nasal flaring, or irregular breathing patterns at this time. He remains comfortable and stable on this mode of ventilation. We will adjust his ventilatory support as needed based on his clinical exam and arterial and venous blood gases. From a cardiac standpoint, the patient has continued to remain hemodynamically stable. His heart rate overnight into this morning ranged from 89 to 140. Blood pressures range for systolics from 80s to 120s, over diastolics 34 to 65. His mean arterial pressures range from 50 to 85. On exam this morning, he continues to remain warm, well perfused with capillary refill of 2 seconds. His pulses bilaterally in the upper radials were 2s, as well as his lower extremities, post-tib and dorsalis pedis, are also +2 to palpation. He has no murmur to oscillation, no irregular rhythms. We will continue to monitor his hemodynamics throughout the day and if any changes occur. Fluid, electrolytes, and nutrition, including GI. The patient's abdomen is soft, non-distended, non-tender to assess to palpation. Bowel sounds are hypoactive. The patient remains NPO. He is currently on IV fluids of D5 normal saline with 20 of potassium chloride, running at maintenance at 32 mL an hour. We will proceed to place a transpyloric feeding tube in this patient and await plans for surgical intervention prior to feeding. From a fluid standpoint, the patient was positive 178 milliliters over the previous 24 hours. His urine output was 2.6 milliliters per kilogram per hour, as well as had a 1 stool overnight. He also had a BMP this morning that showed a sodium of 140, potassium 4.2, chloride of 110, bicarbonate at 20. His bun and creatinine were 2 and 0.26. His glucose reported at 87 with a calcium of 9.4. So we will continue to monitor his electrolytes Q12 and make adjustments as needed. From a heme standpoint, the patient does not have any active bleeding. Currently, he did receive 1 pack red blood cell transfusion for a hemoglobin of 9. He currently, CBC this morning shows a hemoglobin of 13 with a hematocrit of 39.4. His white blood cell count is stable at 12, and his platelets are at 251. We will continue to assess CBCs with differential every day in the morning. From an infectious disease standpoint, the patient did not have fevers. His temperature ranged from 35.5 to 37.7 overnight. We have no concerns for infection at this time, and he is not currently on antibiotics. This patient has the following consults, including neurology, neurosurgery, and ophthalmology. Per ophthalmology exam, patient was noted to have severe bilateral retinal hemorrhages. We will perform a skeletal survey once the child is more stable. The social work team and our scan team is also closely following. My impression is this patient is a 4-month-old infant male, previously healthy, who has now been brought in for concern for non-accidental trauma. His injuries include bilateral subdural hemorrhages, bilateral retinal hemorrhages, and a liver laceration. He is currently critically ill, remains in the pediatric ICU with respiratory distress to failure due to escalation of seizure activity and seizure medication. He remains intubated. We will closely monitor his level of consciousness, neurostatus, seizure activity, and respiratory failure due to this non-accidental trauma injury. The parents are at the bedside. They have been updated on the plan of care. And we will await further management recommendations from our neurosurgery and neurology colleagues.